Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator in the neonatal intensive care unit. And today I am here to talk about chest tubes and pneumothorax, what a nurse's role is in taking care of a chest tube and all that fun stuff. So let's get started. Babies in the NICU do require a chest tube for a variety of the reasons, right? Most of the time when we think about chest tubes, we think of that very standard pneumothorax. Sometimes other things happen, such as a pleural effusion. Babies with high drops often need chest tubes to get fluid off their lungs. Maybe if a baby's had surgery, when I first started back in the day, 20 years ago, if a baby had their PDA ligated, they always came back with a chest tube. It's on this side, Lisa. So that was very common. And now we might have chest tube if a baby has had a repair for a TE fistula. So sometimes these are surgically placed chest tubes, so that's another reason why they may have one. Of course, a baby that's having complex cardiac surgery for repair of a congenital heart defect may have a chest tube as well. The bedside nurse's job after a chest tube placed is similar to no matter what the diagnosis or the reason that we got to the chest tube. You're going to have your drainage system there, you're going to have everything kind of ready to go, you're going to have suction set up, etc. But essentially, this is the same plan: monitoring suction, watching for air leaks, checking your drainage amount, etc. If we can understand kind of why we have a pneumothorax, why we need a chest tube, and then of course what our drainage system is doing, we're going to be in good hands. So let's start by digging into a pneumothorax. I think this picture here is a great picture that's kind of comparing what normal two lungs look like and then what your lung looks like when there is a pneumothorax. So this is a condition where air accumulates in the space between the lungs and the chest wall. The most common cause of pneumothorax in newborns is respiratory distress syndrome. We used to very commonly call it hyaline membrane disease. Essentially, it's a disease from the lack of surfactant. So these underdeveloped lungs. Does anyone remember? I know no one can answer me back because this is a recorded video, but we talked about how there is surfactant delay in other babies, not just premature babies, and that is infants of diabetic mothers, because insulin kind of prohibits the growth, the maturing, the production of surfactant. So those babies are also at high risk of having a pneumothorax. So just think, if there's lung disease, if there's a lack of surfactant, you have a higher risk for developing a pneumothorax. So in respiratory distress syndrome, or RDS, the air sacs are not able to stay open because they don't have that little lubricant around them in the form of surfactant, and so they collapse, and that can lead to your pneumothorax. So this picture to me is a great one, but let's look at some x-rays. So here I have pulled up 4 x-rays. 3 of them are just straight up AP spine, regular babies just like on their back. Look it up. If we look starting here at the top, it's pretty obvious, right? We want to see black, right? We want to see some air throughout the lung, but you don't want to see it isolated over. If you look at the picture below, the right lung in this picture looks kind of what a typical lung would look like on an x-ray. So you can see, if we would compare that right lung to this right lung, there's a big old airspace. It's like we took the picture on the last x-ray or on the last slide and we brought it over here into x-ray version. This is a giant airspace where there is a pneumothorax. You can see it's even kind of pushed the heart even further over on the left side where it's almost touching those ribs. So big old pneumo here. If we look at the second one on the top, it is less obvious, right? We can still see that there's this delineation of a black line along here where it shouldn't be, almost like it's dissecting the ribs. So here's where our pneumothorax is going along. The other lung at the top, it almost looks like there's a collection at the top. Maybe this is your thymus flipped, but it could also be atelectasis or pneumonia. But here primarily we're looking at this left lung. In the bottom AP photo, we also have a less obvious but still important pneumothorax down here in the bottom of the left lung. So it's right here along the ribs, and then of course it's going up a little bit around the heart. So this pneumothorax is so close to the heart. It's in a very interesting location. This final x-ray, we have a baby. We're kind of probably doing a cross table lateral, or where the baby is laying on their side, so we can see that the air is rising. So in this situation, based on what I can obviously see, I would say that this is your stomach. So this is probably your right side. So this would be a right-sided pneumothorax. So the baby's right side is up with the left side down, and you can see how much air has risen up and left just this little sliver of lung. So keeping in mind what these x-rays look like and how much available lung tissue we have to the baby, you can imagine what our signs and symptoms would be. Respiratory distress and difficulty breathing is the hallmark sign of a pneumothorax. This can present as tachypnea, grunting, flaring, retractions. If you look at the baby, they're often going to have uneven chest rise. So where just the side of the chest that does not have the pneumothorax is rising, or one could be going up a lot and one could be going up a little. So uneven chest rise. When you auscultate and listen, you will not hear breath sounds throughout the entire lung that is affected. So it's very interesting to kind of watch these babies breathe and then listen. And sometimes when we listen to breath sounds, you're probably thinking to yourself, there should be breath sounds. I know there should be breath sounds. And then there isn't, and you start putting the pieces together. Other symptoms, of course, could include cyanosis, tachycardia, desaturations, dissension of the neck vein from the pressing on the heart. You may have a blood pressure changes. So your cardiac output may be changing because of the pressure from the affected lung pushing on the heart. This can also cause some pain, some coughing. You're going to look at your chest ray, x-ray, etc. So we've had our x-ray, we see our signs and symptoms, and now we know it's time to put in a chest tube. Often providers will start with a needle aspiration. In a needle aspiration setup, you have your someone's putting the needle into the baby. It's connected to a tubing similar to a med tubing but of a thicker bore with a stopcock and a needle. If you've taken stable, a great certification. If you don't have your stable certification, they have a great video of kind of how you pull back, you turn the stopcock off to the baby, and you push out, and it does this little of cloud like it's coming out. And so that's going to be our needle aspiration. If we're kind of continuously getting it out or we can't fully clear there, the provider is going to exchange that needle aspiration for a chest tube or that reaccumulation of the pneumothorax. So a credentialed provider is going to place that under sterile conditions. The infant should be placed with the affected side up so that the air is available for evacuation. A timeout should stop and occur. Make sure you're doing the right chest, the right procedure, the right baby, and then somebody should be getting your drainage system available. If you've been following along on my Instagram page, you would see that last week, I guess 10 days ago now, we did a chest tube simulation with a pneumothorax during our monthly sim this month. And this is what we were going over, is kind of what is the nurse's role. So prior to the chest tube insertion, we want to explain the procedure to the parents and family, anyone that's available there. We want to ensure that the patient receives any sort of sedation we can give them. On the unit I work on, we are going to be giving fentanyl. Ensure that we have patent IV access, so anything could go wrong. This is a time where we would want to have an IV if one is available to us. And of course, we want to record our basic vital signs. Then we want to be getting the chest drainage system set up, getting that water seal chamber filled, getting the chest tube into a secure position. Often we're taping those to the ground. If your baby is in an open warmer that it'll have a silver bore at the bottom, the chest tube drainage system comes with little hooks, so you can kind of take them out and hook them onto that silver bar. That works as well. You want to get your suction on the wall set to 80, and so that your orange indicator will come out. So let's take a look at the drainage system. So here in the drainage system, we have 5 main parts. I do not have a great picture of the container that the pre-filled fluid comes in. So this pre-filled fluid is on the back of the drainage system. It has a blue stripe down it. So you pull that off and you're going to connect it to the blue circle you see here. So right up here is where you connect that blue container or the pre-filled container. So as you're putting it in, it has this blue stripe on it. You're connecting it to a blue hole, and it's going to turn your water blue. So you're connecting blue to make it blue. That's like one of those little kind of like catchphrases I have for myself. Once you remove that, this same blue area is where your section from the wall connects. This corrugated tube that then connects to a solid kind of core plastic is what's going to connect to the chest tube on your bed. So you bring the suction from the wall, connect it to this blue hole, and then the chest tube in the bed connects to this corrugated system. The suction from this machine is going to default at -20. It's the most common. I've probably seen like literally 5 times in my career where we did not do -20. So you're at -80 on the wall, which is what we just talked about, and that makes this machine do -20. When it is all connected, this orange should kind of balloon or bellow out. It does not need to be perfectly lined up with this little arrow. You need to be able to see it in the window, and that's how you know it's in a good spot. The water chamber, so again, you filled this area with your pre-filled syringe. It's not a syringe, it's like a container. I don't really know how else to describe it. Your water would be blue. So there's going to be some fluctuation. It should come up here right to this little line. A small amount of intermittent bubbling is normal. If you have continuous bubbling, sometimes that happens right when you put it in and the air is coming out from the pneumothorax. But if that kind of happens, especially if it's out of nowhere or a change, you should be checking for a leak also within your system. Over here is where the drainage collection happens. Now, in a typical pneumothorax setting, you're not going to have that much drainage. So this is going to depend on the size and age of your baby as well as the diagnosis. If you have a chylothorax or a baby with high drops, it is very likely that you would have a lot of drainage output here. But in a typical pneumothorax setting, this is usually pretty minimal. So those are the 5 things that you should really be looking at. This is where people tape to the ground. They kind of turn that white piece around, tape it to the ground. Your little hooks are right here to attach to your bed. So the whole system is very user-friendly. It's set up and easy and ready to go for you to get that connected to your baby and get your pneumothorax evacuated. So I know this is a busy slide. If I were you, I'd be like, you got too much going on here, lady. But there really is a lot going on with our parents. Pneumothorax are really unexpected. We don't usually have a lot of warning, often with murmurs, right? Murmurs feel like a big deal, but maybe we've heard it for a couple days. We've had an echo. We've been watching on an echo. A cardiologist has been by. A pneumothorax happens quickly, and the intervention is emergent. That's a lot for our families. So really explaining the purpose of it, what the procedure is, what we as the bedside caregivers in conjunction with our families are looking for, right? How is the baby being monitored? What are we looking at with our respiratory status? What vital signs are we looking at? Well, how much drainage is too much drainage? What could the parents let us know if they see or hear? So those potential complications, if the tube became dislodged, anything that's going on, maybe they suddenly hear a lot of bubbling and they didn't before. Did the pneumothorax reaccumulate, or is there a disconnect somewhere? How do we kind of keep it clean? How are we changing diapers during this? How are we keeping the baby comfortable and changing their position? What are we doing for comfort measures? And then many units are not allowing holding when a baby has a chest tube. That is going to be facility dependent. So just check with your local policy on that one. So to recap, a pneumothorax is a serious medical condition that can happen to any baby in the NICU. It is most common in babies who have respiratory distress syndrome from that lack of surfactant. Again, that can be late preterm infants. Late preterm infants that required PPV, especially if we got to the P of Mr. SOPA where we increased our pressure. If you are, again, on my Instagram page and you saw me talking about how much I love the T-piece resuscitator, this is why. We used to have so many pneumos, and kind of especially these late preterm babies where you're just using too much pressure on them. So it's optimal and essential for you to know signs and symptoms of a pneumothorax and what your role is in helping to treat this emergent condition. They can take days to resolve. This is not one of those things that usually happens quickly. So proper documentation of the drainage system and educating our parents will be key to your daily work. So thank you for joining me on this Tuesday. We, again, have 5 Tuesdays in the month of April. So our last 2 Tuesdays are going to kind of work together to talk about something that is an April, it is the recognized during the month of April. So more to come next week, and please let me know if you have any comments, and make sure you are subscribing so you can see when new videos come. Have a great day.